the rescue of a Thai youth soccer team and their young assistant coach from the cave that flooded and trapped them for over 2 weeks. Hundreds of rescuers from around the world were mobilized, from Thai Navy SEALs to an international group of volunteers. Once rescued, the team and coach were helicoptered to the nearest city's hospital quarantine for a week. No expense was spared, no knowledge or expertise untapped. A volunteer diver heroically lost his life early in the rescue operation. What makes situations like these so exceptional? The life and death stakes are immediate. The lives are identifiable, and we positively relate to them. We're conditioned to think fast rather than to think slow. As psychologist Daniel Kahneman puts it, springing into action, sparing no expense, and doing everything we can to come to the rescue. This happily turned out not to be a case of lifeboat ethics, which asks who should live if not all can be saved. Yet healthcare versions of lifeboat ethics occur daily in the United States and worldwide for thousands who hope they will be selected for a scarce, life-saving organ and who are not so prominently identifiable. Human psychology is geared to identifiable victims in need of rescue. Most of what produces the everyday health care we need, however, is the product of thinking slow and making the hard choices that bring about longer, healthier lives for everyone. Contrast the Thai rescue, where nobody questioned whether it was worth the all-in cost of rescuing 13 people, to the U.S. Congress's unwillingness to fund health insurance for all Americans, and to what happens every day in the United States with respect to health care for millions of low-income, vulnerable residents of our country. How much health care spending in the United States is consumed by emergency room visits is a matter of debate, somewhere between 2 and 10%. But even if we knew the exact amount, would anyone want to deny true emergency care, even at the risk of some people using the ER for routine care? Going all out in emergency situations is a testament to human compassion, but routinely using the emergency room to care for millions of uninsured is evidence of a wasteful, inhumane healthcare system. We want to explore how, in normal times, when the stakes are extremely high for millions of people but not so immediately obvious, we can ethically address healthcare's hard choices. In ages past, when it came to longevity and health, people usually had little choice and so turned their eyes skyward, hoping for the best. Today, by contrast, medical science's power for good is vastly greater than even just a century ago. Infectious diseases like polio, smallpox, measles, mumps, and diphtheria then were common killers. Now vaccinations and antibiotics have either eradicated or radically decreased their incidence. Even more significant are public health measures like clean water, regular food supplies, and other environmental improvements that, with antibiotics and science-based therapies for diseases like stroke, cancer, and heart disease, have created remedies that would have seemed like science fiction only a century ago. To take just one familiar measure of life expectancy change over the past century, an American born in the early 21st century is likely to live to 80, whereas one born in 1900 had a life expectancy of only 47 years. All stages of our lives are caught up in challenging ethical questions raised by modern medicine, healthcare, public health, and life science research. Here's just a sampling of the bioethical